Now we move on to the next session by Dr. Stephen O Brien on the topic placenta accreta spectrum, unexpected at cesarean section. Over to you, Doctor.
I'm going to talk a little bit about the role of the fetal medicine specialist in placenta accretum spectrum. As we all know, it's getting much more common, but our understanding of exactly what it is has been rapidly changing in the last 2 to 3 years particularly, and also how we image and manage antenatally has shifted. And we've moved far more towards high-resolution, obstetrically informed ultrasound, and we'll talk a little bit about that. So what is placenta accreta spectrum? Certainly when I was at medical school, we were always taught that it was where a placenta invaded through a scar, and you had your 3 stages of accreta, increta, percreta. We think that's no longer the case. I don't know if any of you saw the RCOG Green Top guideline that went out for consultation about a year ago on PAS. We're looking, it's much more of a spectrum where there's myometrial dehiscence and then placenta filling that gap with neovascularization. One of the parts of that Green Top guideline was a retrospective literature review by Eric Junyu and the team at UCL to see if there was ever a case of pathologically proven true placenta percreta, so chorionic villi going through a bladder wall. And they weren't able to find one in world literature. It's not that no one's ever thought that they found it, but it hasn't yet been published. So what we think it is a spectrum of disease where you have uterine dehiscence, which we've all seen many times, that repeat cesarean section, with a placenta that grows over that, and then as the uterus dehisces in early pregnancy, the placenta fills in, it attaches to high velocity uterine arteries, and then that causes back pressure, causing vascular malperfusion, vascular proliferation, and all those changes that you see at PAS cesarean section. When you open up and you see this Medusa's head of blood vessels looking at you, we think that's now the result of back pressure from the uterine arteries rather than that invasion perspective per se. The other thing is we now know that there's a continuum of diagnosis between cesarean scar ectopic and placenta accreta. They aren't 2 separate disorders. Babies that are the subject of a cesarean scar ectopic, if they survive and if they're intramural as opposed to being exophytic, are very likely to go on and become a placenta accreta pregnancy later on down the line. The extent of invasion and the extent of defect will likely have been formalized by 22 weeks. So you can scan at 22 weeks in the woman in whom you know that she has had a cesarean scar ectopic, and what you can see at that stage is very likely to be the case, albeit bigger and more pronounced, later on at 30, 32, 34. So who gets it? It's the same stuff we all always know. It's women who've had a uterine insult of any description. So we always quote it's things like surgical terminations of pregnancies, manual removals of placentas, removals of fibroids. In reality, as I'm sure it is in India, the overwhelming majority of our patient burden is women who've had cesarean sections. It's not uncommon. It's certainly going to get more common at the moment in the UK. It's about 0.3% of all pregnancies, and it's only going to go up. We're currently dealing with the back results of what was a few years ago a 30% cesarean section rate. It's now 48, 49%, so our accreta burden is going to at least double in the next few years. We know that it's very, very serious. We used to quote a 7% maternal mortality rate. That's what's currently in the Green Top guideline if you look down in it. We know that through regionalising care and by delivering these women in centres that have got access to everything you need, which is urology, vascular surgery, haematological backup, intensive care, really good surgical access, and most importantly, pre-surgical antenatal planning, we can reduce that down to 0.1%. We can't make it 0. It's still very, very bad. And per cesarean section, if you get pregnant again after cesarean, the best current data we've got is your relative risk might be something like 1 in 300. So what do we need to do as fetal medicine specialists? Clearly we need to scan these women who are at risk of PAS, try and work out if they have it or not, but then we also need to try and work out what to do. A few years ago, we were getting very good at saying, yes, placenta accreta, no placenta accreta. But actually, that's not that helpful. It's good in that it means that the women know that there's a problem and they can go somewhere where they can be looked after, but it doesn't help with the surgical planning. You want to know what sort of placenta accreta does this woman have? Is it a small defect that actually you could think about delivering at 36 weeks? You could try aiming for a wedge excision. You maybe don't need to counsel her quite as extensively. You might not need to think about steroids. You don't need to think about magnesium. Or is it a very big defect invading the cervix, down into the uterines, and actually you need to be thinking about delivery at 30, 32 in a very high intensity unit with all those specialties on board. So our job is to try and describe the lesion in a way that involves multidisciplinary planning rather than just yes, no. That's sometimes a problem we've had with MRIs. So that's why, again, if you read the new Green Top guideline that's not published yet but was out for consultation, instead of having a co-balance between ultrasound and MRI, it's saying ultrasound in experienced hands is probably more useful than just an MRI reported by a non-obstetric radiologist. Those reports, hopefully yours are better, but they just tended to be yes accretor, no accretor. We need to know more than that in terms of looking after this woman. So how do you identify it? Again, it's slightly out of date, but the old Green Top guideline had a list of things to look for that was based on the Sally Collins paper in the White Journal from back in 2015, 2016. And it gave all the things that you look for, from abnormal loss of the clear zone, lacunae, bulge, and everything else. The important thing to realize is these are all just describing the anatomy using ultrasound signs. This is what you see, as I'm sure we all know that's a fairly standard placenta accretor. All those signs on ultrasound are just different ways of describing the same anatomical process. And so we need to be trying to work out, yes, I have these signs, but what does it mean surgically? But these are roughly what the signs look for, as I'm sure you're all aware. So if we go back to our checklist, if we're looking for loss of a clear zone, that's the loss of a clear zone up the top there. So you can see there's some myometrium around the side, some myometrium around the side, none up the top. I've deliberately picked, these are pictures taken from a scan machine that we had that we got rid of 3 years ago. So these are not best case pictures. These are all what you will see on a wet Tuesday when you're tired and your children have been up with you all night and it's the last patient on the list. So hopefully this is relevant to normal practice. You see loss of a clear zone transvaginally as well, as I think one of our colleagues said, when you're evaluating placenta accreta, a transvaginal ultrasound is absolutely vital and shouldn't be missed. You have to have a full bladder. If you've got an empty bladder, you won't see anything. You need to have something to put your sound waves through. You have loss of a clear zone there on transvaginal as well, and you can see that there's no myometrium and there's some hypervascularity between the placenta, which has abnormal lacunae, and the bladder wall. People describe abnormal placental lacunae. Well, what's abnormal? Clearly, you can just count them, but no one has a nomogram of how many lacunae. What's probably more useful is looking for those high flow vessels. So if you see the vessel going into the lacunae themselves look disordered, but you can see the start of some aliasing within those vessels. So they're high flow, higher pressure than we would usually expect. We talk about bridging vessels. This is your theoretical bridging vessel. So down at the bottom, the one going from your left to your right, theoretically through the bladder wall, but as we said, it's not actually going through the bladder wall, it's just abutting against it. It's called a bridging vessel. In reality, it's just one of those vessels that's bulging out behind the bladder wall. You can make them look as scary as you would like to. So if you're ever sat with your surgical colleagues and you'd really like to scare them before they do one, if you just change the indices and turn up the gain, you can make them look very, very bright and very, very alarming. But fundamentally, they're the same thing. The bridging vessels, again, are just where you have those bulges, and they just represent that defect in the myometrium with vasculature on top of it. We talk about bulges in the placental wall or bulges behind the bladder. Again, it's the same thing. It's that defect with disordered placenta coming behind it without a basal membrane to keep it there where it's supposed to be. It's normally fairly obvious if there is a bulge, particularly if you've got women with a high BMI. It may be the only thing that you see. It's very tricky to do your Doppler in that scenario. You'll get it at different points from the left and the right of the woman. You will have your defect somewhere. You might have a whole field defect, in which case you'll see bulge everywhere, but in most women it's on part of the uterus of the anterior abdominal wall, and you want to describe where it is on the left or the right or in the middle. And again, it'll look at all sorts of different things. So this is again bulge, but you can see abnormal placental lacunae behind it. All of these aren't yes, no, it's present, it's not. They're all variations of the ultrasound appearance of the same pathological process. This is the same thing. So this is the same woman as previous, but on transvaginal. Again, you've got that placental bulge, but actually the placental bulge isn't the most important thing. Behind it, you can see those big dilated vessels, the abnormal lacunae and the abnormal placenta. Talk about uterovesical hypervascularity. Again, that's theoretically what it looks like. It's the same thing. It's just you haven't caught that vessel in cross-section, so it's not a bridging vessel, it's just vascularity, but again, same process. Again, you can make it look very scary if you would like to scare your surgical colleagues. The increasing thing that we're finding is very useful in not only our centre for the southwest of England, but in the centres for Oxford and particularly in London, is the role of cervical and cervical hypervascularity. One of the big questions when we're planning delivery of these women is, are we going straight for a primary hysterectomy or can we do a wedge excision? From a surgical perspective, if you've got a very vascular cervix, it's very, very, very difficult to preserve it because it'll just bleed and bleed and bleed, and as you try and put your sutures through it to stop it from bleeding, it's just like stitching through pate, and it just falls apart and you end up having to go lower. The less vascular your cervix is, then the less likely you are to need to do a hysterectomy. And so imaging the cervix, we're using your Doppler, ideally transversely, because it can be difficult to do longitudinally, will give you a good idea of the vascularity and allow you to manage your surgical plan. That's really the important part, which is, as fetal medicine specialists, yes, we need to tell our colleagues if there is or if there isn't PAS, but we also need to try and describe the anatomy in a useful and clinical way. So, for example, this is the same woman. So this was her scan at about 32 weeks, and then this is her on opening. And you have that bulge behind the bladder, which you can see just there under those fingers. So what you want to do is describe where you see the bulge, describe what it does to the cervix, and then use that to make a plan. So this is another case. So this is a case with much more severe placenta accreta on a transvaginal scan, and you can say that there's a lower left network of large, slow flow vessels between the uterus and the bladder. There's very little visible myometrium, and there's a pronounced bulge, and it's close to the cervix. If you then turn your probe transverse, you'll see the same thing, but in a different plane, and you'll see that large bulge on the left where the defect is. And then, if you then go to surgery, that's then what you see. So you have that large defect on the left, fairly low. And that means you can make your surgical plan to mean that you can remove it and with a view to do a hysterectomy from early on. When you're talking to your colleagues, it's about thinking, what is it that you want them to know? So there's a big defect, it's close to the cervix, and if it's got lots of cervical vascularity, you may want to think about ureteric catheterization. It helps in terms of identifying them so you don't accidentally put a stitch through them while you're doing your operation. That's what it looks like when it comes out. You have your defects and very little remaining cervix down the bottom. Fab. That's it.